So it is my great pleasure to present Dr. Jaideep Behari, our next speaker. Dr. Behari is the director of UPMC Liver Steatosis and Metabolic Wellness Program. He's also the director of Translational Research for Hepatology, University of Pittsburgh Liver Pancreatic Institute. He's the associate director of Pittsburgh Liver Research Center, University of Pittsburgh School of Medicine. Dr. Behari is a renowned speaker in MASLD. His clinical interests include the evaluation and treatment of MASLD, alcoholic liver disease, and the management of obesity and MASH patients. He has a keen interest in research and has several NIH grants and has published numerous articles in national journals. I'm so glad that we have a nationally recognized hepatologist, and I'd like to travel Dr. Behari for traveling from Pittsburgh to talk to us. Dr. Behari.
Very much. I really appreciate this invitation, and it's great to see many with whom I went to medical school. So it's really wonderful to be here amongst all of you for this fantastic conference. The first two talks they really resonated with me, and I had no idea what Dr. Gandhi and Dr. Kulkarni were going to say, but you will find my message will be highly complementary to their message. And I'll pull up my slides in a second. We'll jump right in, and these are my disclosures. And here are the learning objectives that you know. So this is my overview of my presentation. I'll really try to focus on 4 important points. I'll give you very quick updates on MASLD and MASH, which are hot off the presses within the last 6 months to a year, and encourage you to start using this new terminology and give you some rationale for why we changed the name. The second important point I'm going to address is the correlation with obesity and how you figure out this issue of lifestyle versus obesity from my perspective as a transplant hepatologist. Third, we'll talk about really the topic of this conference, which is evidence-based lifestyle as it pertains to liver disease. And finally, some practical issues. How do you and I, with busy clinical practices, implement these lifestyle issues on a day-to-day basis? And for those of us who are living our lives in the trenches of clinical medicine, it's really important to have some kind of framework on how to address this in your clinical practice. So most of you, I'm sure, have heard of this, and I hope are aware and have used this new terminology. We are no longer using the word fatty liver disease, but we'd like to start using the terminology steatotic liver disease, where steatosis is really the technical term for excessive liver fat in the liver, which has been defined as 5%. And there is some physiologic basis for picking that specific 5% because it does make the liver insulin resistant. There is a continuum now, which is a new definition that has been introduced. On one end is MASLD, which is metabolic dysfunction associated steatotic liver disease, which used to be called MASLD, or non-alcoholic fatty liver disease. And I think this is really important because it's completely relevant to our talk today, where you're not just ruling out alcohol and then wondering what's going on with the liver, but actually start with the discussion of metabolic dysfunction. The second new terminology, which even hepatologists weren't using before, and this is absolutely brand new term, is called MASLD, which is MASLD with excessive alcohol use. And Dr. Kulkarni mentioned alcohol is a very important risk factor for cardiovascular disease. There is no doubt all of you know that alcohol is a primary reason for alcohol-associated liver disease and cirrhosis, but that relationship now extends even to metabolic dysfunction-associated steatotic liver disease. Now, where do you draw the line? And fortunately and happily for me, that number has been steadily decreasing. And I would consider 2 drinks average for men and 1 for women to be absolutely the upper limit of safe. Anything above that should be considered at-risk alcohol use. Now, there are, of course, some people who are genetically endowed and can drink as much as they want and never have any liver problems. But I think for most of us, the level is surprisingly low. On the other end of the spectrum are individuals that have clearly alcohol-associated liver disease. And then there are some specific etiologies that we identify in our subspecialty clinics, which are based on genetic drivers of liver dysfunction, such as Wilson's disease or a specific drug-induced liver disease, such as amiodarone, tamoxifen, etc. And then we also see this very small sliver of patients that have no metabolic risk, no alcohol use, no identified genetic risk, and they are labeled as having cryptogenic steatotic liver disease. And there's a lot of interest in identifying these monogenic and perhaps polygenic reasons for having liver steatosis. Now, what's interesting is that the new definition is a positive definition. You do not have to rule out anything. But if you have liver steatosis diagnosed with an imaging study or by a liver biopsy, and you have one of 5 metabolic risk factors, which is essentially the metabolic syndrome, then you can make a positive diagnosis of MASLD. You can certainly have dual and triple etiology liver disease, so you can have coexisting liver disease from alcohol, you may have hepatitis C, Hep B, etc. So we certainly see a single etiology, which is MASLD. We can have dual etiology, which is with overlap with alcohol, etc. So this is an important change for you because you can start actually coding for it. Now, for those of you who use Epic, I can tell you that MASLD is now MASLD has been replaced by MASLD. So if you're coding in Epic, you can actually pick MASLD as one of your billing diagnoses, and NASH, non-alcoholic steatohepatitis, has now been replaced with NASH. So you can confidently go ahead and use it. The ICD codes remain the same, and so your billing practices should not be affected. So what exactly do we mean by MASLD and NASH, and what do we talk about from a histologic perspective? I just wanted to give you this very quick slide from one of my patients, because it will put the treatment into perspective as we talk about this in a second. So I've highlighted 3 things here with 3 different colored arrows. The most obvious, of course, is the fat and the tissue, which are the white globules you are seeing, which is pointed out by a blue arrow, which is a fat globule within a hepatocyte. But there's also the green arrow pointing towards a focus of lymphocytes. So that's an inflammatory focus. And then the red arrow is pointing towards what's called a ballooned hepatocyte. This is a liver cell that's dying as a result of oxidative stress. If you have these 3 conditions, features on the histological biopsy, that's when we call it MASH, steatohepatitis, where steatosis is fat, and the hepatitis part of it comes from the inflammation and the presence of these balloon hepatocytes. On the right side for you is the same slide that's been stained with a trichrome stain, which highlights fibrosis or collagen or scar tissue inside the liver. And this is being laid down in a 3-dimensional pattern. It's not usually localized, although it can happen in rare situations, but generally it's diffusing throughout the liver. And the yellow arrows are pointing towards the blue stained collagen, which is being laid down in a 3-dimensional network throughout the liver. And if this patient had very advanced fibrosis, you can see there's almost the formation of a cirrhotic nodule where hepatocytes are present in the middle, and then around it is the blue circle, which is being laid out. I'm not sure if you can see my cursor up there, but that's what fibrosis looks like. Now, this is important for you to know because there's been a very nicely done prospective natural history study showing that the only feature that can predict a bad outcome from the liver's perspective is the presence of fibrosis. And this study, published in the New England Journal a couple of years ago, suggested that individuals that have cirrhosis, which is F4 fibrosis, are the ones that are at increased risk of liver-related complications in a short term. And this study was only 4 years, but the natural history of cirrhosis is actually 15 years. So this is, of course, a biopsy followed by 3-4 years, and tells you that thankfully a very small percentage of patients will develop liver-related complications, but clearly they're at risk, and the cumulative incidence of liver-related complications will continue to go on, depending, of course, on the age of the patient. Now, there is a pathway for care that has been proposed for MASLD and NASH through the American Gastroenterological Association, which I think is very fascinating, and we're not going to dig into it because we're going to focus only on the first row here for this talk and for this forum, which is lifestyle intervention. And I'd like to highlight for you that even for patients that we're seeing in our transplant clinic who have either decompensated cirrhosis or are post-transplant, lifestyle intervention is a very integral part of that message. And going back to Dr. Gandhi's very important message in her introductory remarks, that the presence of all of these really powerful agents for diabetes are really not making much difference for us. And the same hype also existed perhaps 30 or 40 years ago that Dr. Kulkarni may know about, is when the statins were discovered. And the statins were targeting actually a liver enzyme, which is HMG coenzyme A reductase. But really, sure, we have some improvement and a dip in the incidence of heart disease and deaths from heart attacks, but the difference has been relatively minimal. And I am afraid that the same might also be true for liver disease. But that's an important message. And also in this algorithm is a focus on weight management, with which steatotic liver disease is very closely associated. You also may have heard, and I just wanted to mention this but not talk about this, is that the first FDA-approved therapy for MASH was approved literally 6 weeks ago. And this is a very, very interesting drug. It's a thyroid hormone receptor beta agonist that's targeting liver-specific thyroid hormone receptor beta. So it's not present anywhere else in the body. Very well tolerated. I have patients who've been on clinical trials with this drug. And it does improve fibrosis as well as steatohepatitis. I put this slide up there to tell you a very important reason. For an important reason, and that reason is that when you look at the improvement in fibrosis, which is the top left figure here, you will see that the response over placebo is a very modest 15%, and that 65 to 75% of the patients will be non-responders. And I will leave you with the thought that this drug has been priced at $3,900 a month per patient. So that's the kind of challenges that we're going to face, and the availability of these antifibrotic therapies are not really going to make that much difference in our patients in the near term. And this is a map showing you the prevalence of MASLD, and very similar to the one shown by Dr. Kulkarni. And of course, South Asia has the dubious distinction of being amongst the in the areas of the world with the highest prevalence of MASLD. The other thing I wanted to point out to you, which is very relevant for all of you practicing here in Texas, with a very high percentage of Hispanic American population, is that there is a specific polymorphism called PNPLA3, which is associated with a very high risk, independent of metabolic syndrome, for MASH and progressive liver disease, cirrhosis, and liver cancer. And amongst Hispanic Americans, there's a very high prevalence of this polymorphism. But in patients of individuals of South Asian heritage, it's actually fairly low. So it just tells me that perhaps either there are other polymorphisms that have not been discovered, or perhaps the environmental effects, the diet and the lack of physical activity, as Dr. Kulkarni mentioned, are actually very important for animals. So moving on very quickly to a second important point that I want to mention, which is perhaps more relevant, directly relevant to our topic of discussion today, and that is to recognize and address obesity in your patient population. So I'll start off by saying that I'm really looking forward to the endocrinology talk later today, and I heard Dr. Kulkarni's talk with great interest. I'm a transplant hepatologist, and I'm sorry, I'm going to take the credit for what causes metabolic syndrome in the first place. Now, it turns out that natural history studies have been done looking at obesity and who gets into trouble metabolically if they have obesity. And there have been several incredible longitudinal studies that have been done in Germany as well as in the UK with the UK Biobank. And the one thing that separates individuals who have obesity and metabolic syndrome or metabolic dysfunction versus those who don't is the presence of hepatic steatosis. So by definition, the presence of liver fat, hepatic steatosis over 5%, is the definition of metabolically unhealthy obesity. So think about that for a second. The liver is getting unhappy years before you're developing any manifestations. And in my clinic, I see patients with prediabetes or with fasting glucose levels of 99 or 100, but they are sent to me for management of hepatic steatosis. And they have very mild fibrosis. We don't really want to treat them with anything, but they're the individuals where you get the biggest bang for the buck with lifestyle modification. So this is a very, very important point to keep in mind, that I love your hashtag, live the dream, but I wish the M stands for MASLD, because that's what's underpinning all of the subsequent health-related consequences. Now, it's also important to keep in mind that in some populations, you know there'd be a very high prevalence of diagnosed or undiagnosed hepatic steatosis. The best known is type 2 diabetes. 70% of your patients with type 2 diabetes will have underlying hepatic steatosis. And the new society guidelines from the Society for Clinical Endocrinology is to screen those patients with a non-invasive test for advanced fibrosis. But in patients that have obesity and a BMI greater than 40, the prevalence is almost 100%, not quite 100%. So there's these individuals who remain metabolically healthy no matter what their BMI is. And it's a very interesting phenotype, I think, but it's close to 90% or higher once the BMI exceeds 40%. Now, I think it's very important to keep in mind that these BMI definitions are for people of European heritage, and our cutoffs for South Asians is very, very low, much lower than that. What that cutoff should be and where we define that, I think, remains not very well defined, in my opinion, especially because most of our patients are developing truncal adiposity or a visceral adipose tissue, which may not be well represented just by BMI, which is a very poor marker of metabolic health. But these are two very important things to keep in mind because, for example, in my patient population, there's a very high prevalence of obesity. In fact, it's uncommon for me to see a patient that does not have obesity. And what I've noticed is, and perhaps this is a referral bias, is that over the years, so this is something we published more than 10 years ago, and this is data that is just from a few months ago, is that there has been a trend towards increasing obesity in this population. So we're not just seeing more obesity, but we're seeing more severe obesity, which remains the fastest growing segment of the US population. And the other worrisome thing is that severe obesity gets established very early on in life. So the youngest patient that I have in my clinic who has MASH-related cirrhosis, thankfully still compensated, is only 22 years old and was diagnosed with MASH with a biopsy at the age of 13. So it's very sobering thought and something that we all need to be very mindful of because obesity is embedded in your clinic population. And there are many studies suggesting that physicians don't even notice obesity until the BMI hits 35. So very important to keep that in mind. The other challenge is this concept of truncal adiposity or visceral fat. You know, in my clinic, we train MAs to do waist circumference measurement, but we have such a high turnover of staff. The next person who comes simply doesn't know what it is or how to do it. So it's a very challenging problem, but it's something that you have to constantly keep in mind. And I think a waist to height ratio might be a much better marker than using BMI. It's just easy, and so we do it. But I think there are better ways to do it. Now the question is, how does BMI impact patients with MASLD? Since I'm focusing on the liver here, so we asked the question, you know, like many of the health systems in Texas, we have a gigantic health system with 40 plus hospitals, I think, currently. And so we have a very detailed electronic health record data set that goes back decades. And so we were able to pull up a very large amount of patients, over 40,000 patients who had been diagnosed with MASLD, and we did all of our due diligence to exclude other liver diseases, to simply ask the question, how does BMI impact? Of course, acknowledging that BMI is not the best marker for metabolic health, but remember, by definition, if you have steatotic liver disease, you're metabolically unhealthy. So these individuals all had an ICD-9 or 10 diagnosis of MASLD, and we found that individuals that have a BMI greater than 50 are at extraordinarily high risk. The second highest risk, though, which was surprising to us, are individuals that are now called as having lean MASLD. They are individuals that have a normal BMI. And I suspect that many South Asian individuals would fall into that category because their BMI simply does not capture their metabolic dysfunction, since all of that fat is around their waist. So that's a very interesting fact that we found. The other interesting thing was that individuals with BMIs of around 25 or 30, so that's what would be considered overweight according to the WHO definition, doesn't have the least mortality. So it's very fascinating. There have been some studies hotly debating this topic, and some individuals have called this obesity paradox. I think it's very controversial. I'm not going to dig into that today. But the other thing we found was that as BMI increases above 40, there is a very significant increase in all kinds of bad things happening to these patients. So there's an increased risk of liver decompensation, there's an exponential decline in their chances of getting a liver transplant, and they have a significant increase in overall liver-related problems. The challenge, of course, is that when you tell patients to lose weight, very few are successfully able to do it. So we published this data from our program. We said, well, how many of these patients, after they've seen us, these are not undiagnosed patients, seen a specialist, making the effort to drive a long distance, see us, and are told to lose weight, actually end up gaining weight. And this was shocking to me when we looked at these data, that there were 15% of people who saw us and within a year actually ended up gaining weight. Very surprising, right? And so we've dug into this a little bit more. And I have to say that a primary reason for weight gain is iatrogenic. Very frequently, it's someone who's diagnosed with poorly controlled diabetes, got placed on insulin, which causes significant weight gain. There's also a higher prevalence of depression and anxiety, and many antidepressants and antipsychotic medications associated with weight gain. So I'm not sure, but we are finding that this is not really patients not paying attention to us, but iatrogenic weight gain caused by medical therapy. The good thing was, perhaps the ray of hope or the silver lining, is that the more we saw the patients, the better the chances of losing weight. So clearly, healthcare providers can make a difference. And so the graph on the right really shows that individuals that had a higher BMI and saw us more frequently during that 1 year had a higher probability of achieving a 5% weight loss. So that's reassuring. It's also encouraging. It tells us that if we care about the patients, clearly care about their health. But if we pay attention and we give them the attention they need, then they tend to do better. A very common question that I get asked, that you probably get asked too, is it reversible? Is steatosis reversible? And how quickly can I expect to see that? So after having heard that question for a decade, we actually decided to empirically test that. And so we did a study where we were looking very frequently, every 2 weeks, using a non-invasive test called transient elastography or FibroScan to brand name. And we asked the question, how long does it take for steatosis to improve for someone that's on a hypocaloric diet? So these were individuals who were on a modified, fast, hypocaloric diet. We were allowing them some degree of solid food, but they were around 1,100 to 1,200 kilocalories per day. And on the left, you can see the bar that there is a very rapid decline in liver steatosis, at least measured through this technology, within 4 weeks. And after that, it pretty much flattens out. So that's great news because it tells us the liver responds very quickly, and lifestyle change, dietary modification will result in very quick resolution of ectopic fat, which is the liver. And so that's good news for us. On the right, you see an MR spectroscopy, which is the most accurate way of measuring liver fat, showing you that between week 0 and week 12, there is complete resolution. So the answer is A, how fast can you do it? As little as 4 weeks, and can you completely resolve it? The answer is yes. Now, the problem is that maintaining weight loss is a hard problem. And so most of these patients who were on the study actually regained the weight and their steatosis came back. So this is a very, very dynamic process. The second thing we've discovered is that you may lose weight, but your steatosis may not completely resolve. And this was a North American study of individuals, and none of the patients in the study were of South Asian origin. But in this study, they were all BMI 35 or greater. They were put through an intensive lifestyle program for 6 months. And we found by using CT metrics, which is not the most accurate, we found that some individuals completely resolved steatosis, but some didn't, even though they had the same amount of weight loss. So I suspect that there are some other factors, perhaps genetic, perhaps body composition, that make a difference. So we don't know why exactly weight loss and lifestyle change may not be sufficient for some individuals. There's only been one really well done randomized clinical trial looking at the effect of lifestyle change on resolution of MASH. And in this study, which was from Cuba, it was found that individuals that had 10% weight loss had improvement of MASH, in fact, almost complete resolution. There was fibrosis regression in almost all of them. The steatosis resolved in 100% of them. But unfortunately, if you see on the bottom right, only 10% of the people were able to lose 10% of their body weight. So it's a very hard thing. It's a very important take-home message. We tell our patients to lose weight, change their diet. It's a very hard thing for most people to do. So I'm sure all of you have wondered, as I did for a long time, why? We tell the patients to go change their diet. I'm sure they do it. I'm sure they try it because we see a weight loss. But then a year or two later, everyone is back to where they were. This is our shared experience in clinic for thousands of patients, perhaps with ourselves. And the answer is that it's been known for over 100 years that weight regulation is a highly complex trait. It's a very, very complicated phenomenon that's driven by genetics, by neurohormonal mechanisms. And this theory is called the body weight set point theory. And so once your body gets used to a certain amount of weight, it defends it. And more importantly, it defends the fat mass. So if you lose fat, your body will tend to go back to the fat mass at result. So this is called the set point theory that was proposed decades ago. But very few of us realize that this is a very big challenge. Now, in most individuals, weight regain after lifestyle change within an initial weight loss is common, and usually happens 6 months, weight loss, everybody's happy, you tell the patient, everything is good, see me in a year, they come back in a year, all the weight has come back. So this is the most common outcome, initial weight loss followed by weight regain. Now, this is a remarkable study done, and some of you may have seen this show, which was called the Biggest Loser show, where people lose 100, 200, 300 pounds with intensive lifestyle and dietary change. And in this study, the group from NIH brought these patients back several years later and found that the majority of patients had regained all of their weight back, and their basal metabolic rate had gone down and never recovered after that weight loss. So their bodies had become so efficient that even a very small increase in caloric intake caused an exponential increase in weight regain. This is a very sobering thought, and we have to keep this in mind. Now, we see patients that are really sick and undergo liver transplant, and we found that after transplant, there's an initial weight loss, but based on their initial BMI, our patients very quickly regain the weight within a year. And that trajectory is really dependent on their weight before they transplant or before they got sick with cirrhosis. So very powerful forces, neurohormonal and genetic, that drive this condition. So this is an important point. It's also important to keep in mind, since we're talking about GLPs and incretin mimetics and all the exciting drugs for weight loss that are coming, that when you stop these drugs, the weight very quickly bounces back. This is a very important point that I'm sure all of you are aware of, that these drugs have to be continued lifelong. So these are all leading up to one very important message that I want to tell you. And if you're wondering, well, how's it relevant to today's talk? And that is that sustained weight loss through lifestyle modification alone is extraordinarily difficult for our patients. And therefore, we have to start thinking about metabolic wellness and health independent of weight loss, or at least agnostic of weight loss. If weight loss happens, we'll take it. But if it doesn't happen, it doesn't mean failure for our patients. And so that's the segue for our third part of our talk. So this is an example of a patient of mine who had an initial ultrasound. So the red circle is a steatotic liver. You compare it with the renal cortex, which is the green circle, and you can tell that the liver is brighter. So that's an echogenic liver to a radiologist, and they will call this a fatty liver. And on the right is the same patient after lifestyle change, who also happened to lose a lot of weight because of that, and that is completely gone. And so if you compare the right picture for the same patient to the left picture, you will see that the echogenicity of the liver is the same as the kidney. So again, another example of resolution. Here's a very striking example of what lifestyle can do. So in 2017, a patient of mine had a liver biopsy because she enrolled in a clinical trial. 2018, she lost a lot of weight. She made lots of lifestyle changes, continued on the clinical trial, and everything resolved. No fibrosis, no steatosis, no inflammation, and pathologists read it as a normal biopsy. So reversal of MASH, real life example. And we were very happy. We said, this is great. You're not on the placebo, you're on the treatment arm, you're responding. And then the pandemic happened in 2021. She gets a protocol four-year biopsy, and everything is back. And what's happened in the meantime is she's regained much of the weight, her diet and lifestyle have gone back, she stopped exercising, and everything came back. So in 21, I joked with this patient, I said, you know what, I think you're on the placebo, because this is all you. You resolved your condition, and it came back. And so we really didn't know, but just last year, we were finally unblinded. The study ended after 7 or 8 years, and of course, she was on the placebo arm of the study. So this is a classic, striking example of the impact of lifestyle. And I always show this slide because it tells you, yes, you can. So this is secondary prevention. You know, the disease is established. We could have easily picked, and in fact, we did pick pharmacotherapy for this patient. And so I think there's a very interesting talk today about reversing type 2 diabetes, but here's reversing MASH. Now, the other interesting thing is that the majority of individuals who have MASLD actually will not qualify for at least much of the pharmacotherapy that's being developed in clinical trials. So most of our clinical trials are targeting stage F2 or F3 liver fibrosis. There's also a lot of interest in trying to reverse or prevent progression of cirrhosis or compensated cirrhosis. But that's not the case in my clinic, where a majority of patients, about 65%, have very mild fibrosis. They have steatosis, perhaps. They may have high liver enzyme metabolic syndrome, but they're not going to qualify for this $4,000 a month drug. And so we have to think about lifestyle for these patients. Now, there are several things there's ample evidence, and I'm not going to talk about it. I'm sure all of you know about the Mediterranean diet. I'm sure you recommend it to your patients. Dr. Kulkarni gave a fantastic perspective on how you do it for South Asian diets. She talked about alcohol, which I completely agree with. I think the levels are lower than we all believe. And I also recommend, if you have steatosis, the best option is not to consume any alcohol. You decide what's safe for you is. I think the right amount is 0. And then moderate intensity aerobic activity, which is in all of the guidelines, although very few people are able to achieve it. So I'm not going to talk about that, but I'll give you some alternative things to think about, which I get asked about by my patients a lot, and perhaps you do too. And the one dietary factor that I find is very, very critical, at least in my clinic, and I'm sure it's true for yours, is the consumption of sugar-sweetened beverages. Are patients underreported? You have to ask this question in many different ways to get the right answer. It's almost like alcohol. You have to ask the question in a lot of different ways. And this study from more than a decade ago, almost 15 years ago, showed that there was an association of MASLD and sugar-sweetened beverage independent of metabolic syndrome. So the liver is one of the most important organs to handle fructose, which is 50% of sucrose or sugar, refined sugar, and so it has a disproportionate impact on the liver. And also, the more sugar-sweetened beverages a person consumes, the more severe their MASH is. So I think in 2024, we shouldn't be arguing about this. This is a very, very important factor. But this is a very remarkable study done a few years ago at UCSF, where they took pediatric patients with MASLD, and they put them on an isocaloric fructose-restricted diet, where the fructose in their diet was changed to starch with a maximum of 4% fructose. And these individuals, these pediatric patients, got isocaloric diet. So you're absolutely isolating the impact on fructose. You're not claiming that they're just having less calories and therefore their fat is improving. And they found that there was a very striking reduction in de novo lipogenesis, whether or not these children lost any weight. So to me, this is such a convincing argument for cutting out all sugar in your diet. If I had to give you one message, forget everything I'm telling you today, take home one message, is there is no reason at all physiologically for any of us to consume refined sugar, whether it's liquid or solid. And that's, I think, a very, very important take-home message from my perspective. I think completely applies to every other subspecialist that's going to present today. The other common question I get asked is with intermittent fasting. And there are some data coming out now that intermittent fasting is actually great. There are data across all other comorbidities, but it's nice to know that certainly the liver will respond very well to it. I'm finding that with some patients, intermittent fasting is leading to a weird form of binge eating late at night. And so it's very common not to eat anything at all and then have very high amounts of caloric intake late at night. So that's something to keep in mind. A better alternative, I think, is this alternative day fasting combined with aerobic activity, which is what, in Indian traditions, it's so deeply embedded, right? I mean, all of us have relatives and family members who fast 1, 2, 3 times a day. There's lots of religious events where fasting is considered an integral part of that. So it's very interesting, and that's certainly true for Christianity, it's certainly true for Islam, where fasting is almost embedded in the culture. So I think this is a very fascinating data that helps us. A very interesting study, which you will not find on PubMed because this came from the psychology literature in the Journal of Consumer Psychology, is planned hedonic deviation or simply a cheat day. And I think this works great because if you say, I will never have sugar again in my life, it's depressing. But if you say, I'll be great Monday through Saturday, but I will allow myself one nice meal, and maybe that's the day you eat out with your family. I think that works really well with my patients, and I started to use this now, and I feel this is one of those little things, those little cheat codes that work really well for your patients. And then there is some data suggesting that resistance training may also impact hepatic triglyceride and not just aerobic activity. So it's good to know this. It's certainly good to encourage your patients. And finally, I'm sure all of you are happy. I see lots of coffee cups around here. Is that coffee consumption, at least in epidemiologic studies, has been associated with decreased risk of liver fibrosis. So I think we have some good data. I think there's a lot more work that remains to be done, but I think we know enough at this point to actually make a difference in our patients' life. So in the last couple of minutes, I'm going to very, very quickly try to answer the question. All this is great, but how do all of us who are in busy clinical practices implement these ideas? And this was something that we had struggled with in my clinic for many years. Where do you start, right? If you see 10, 12, 14, 15 patients a day, all of whom require this advice, how do you do it, right? It's a very important technical, practical problem. And so how do you do this is really the question. And the way I suggest, at least for patients with MASLD, but you can swap MASLD for anything. You can make it type 2 diabetes, cardiovascular disease, hypertension, and really think about it in 4 quadrants: lifestyle management, managing cardiometabolic risk with or without pharmacotherapy, managing obesity when you need it, and then for me, what's important is liver-directed pharmacotherapy, since I see so many patients that come to us with advanced disease. And there's a very nice 5 A's of obesity management that were developed by the Canadian Obesity Association, and that I think are very perfectly matches up with lifestyle management. One important point I will tell you is that many physicians miss this transition where lifestyle management alone is not sufficient and you have to introduce pharmacotherapy. And so in my clinic, I'm very mindful of this. Some patients truly do need the right treatment, whether it's endoscopic sleeve gastrectomy or a gastric bypass. At some point, you have to bring in pharmacotherapy. But these are the 5A framework that we've adapted for our patient-centered lifestyle management. So in a new patient packet, which is the ask part of it, if people are coming to see a subspecialist, they don't mind filling it out, at least 90% of them do. We have an assessment of its specific questionnaires that I'll tell you about. We advise them, we agree on a treatment plan, and we assist them by finding whatever resources they want. So I think this is a framework that all of us can use. We use the Promise 29 questionnaire, which is an NIH open source questionnaire that gives you 7 domain scores. You can substitute your PhD 9, etc. with it. And I highly recommend because it makes your care very patient-centered. It takes about 5 minutes. Of course, there are some issues, certainly in a very diverse population like Dallas, you might have to use the Spanish version of this questionnaire. We use the Mediterranean diet questionnaire, which came from the famous Freddie Med study. It works very well for us because I have a very high population of European heritage. You may have to adapt it to your population, whatever that might be. But we find this is a great starting point and a quantified way of measuring diet quality. We screen for alcohol using Audit C, and I highly encourage you to start using phosphatidylethanol, which is a very accurate blood biomarker for recent alcohol consumption, especially if you diagnose someone with MASLD. And then we use the physical activity vital sign. It literally takes 5 seconds, and it gives you the number of minutes of activity per week. And many patients report 0 or 5 or 10 minutes a day. It's a wonderful starting point for you to have a conversation. And I ask them to make that 5 minutes a week to 10 minutes a week when they see me in a few months. So this is a very nice quantified way of starting that conversation with your patient. Final slide, final thought I want to leave you with. We are all familiar with the stages of change model, the trans-theoretical model of behavior change. Patients are in pre-contemplation or contemplation stage. By the time patients are seeing me, they have had so many cycles of dieting, weight loss, relapse, weight regain. Everybody is in the relapse phase. It's very uncommon for me to see someone that's in a pre-contemplation or contemplation phase. I love the model on the right. This was proposed by a Stanford psychologist called B.J. Fogg. And this model suggests that there is this continuum between motivation and ability. High motivation, high ability, low motivation, low ability. And his suggestion is to make your activities so easy that you guarantee success. I think it's a remarkable thought. And so I ask my patients if they've never exercised before to start with 5 minutes, as long as they promise me that they can do it every day. And that becomes a cascading effect. It's like a stone rolling downhill that can add up to a very dramatic lifestyle change over time. So these are the key takeaways. Lifestyle modification, very important. Please recognize obesity, manage it appropriately. My one take-home message, focus on sugar and sugar-sweetened beverages for the liver. And then hopefully you'll be able to implement a structured lifestyle program. So I have a big team. They do all the hard work, and thank you very much.
Great presentation, Dr. Behari. I have one question. Being an endocrinologist and a strong proponent and advocate for intermittent fasting, what are your thoughts on lean fat people? Like I see a lot of South Asian patients who are not obese. Their BMI is less than 23, but their liver enzymes are normal. But when we do imaging, they do have a microsteatosis.
Yep.
So those patients, I encourage them to go on an intermittent fasting diet. And so intermittent fasting is misunderstood. People think that, during the eating window, they can binge eating, which is not the real intermittent fasting. But what I see is, I don't see any changes in the weight in Southeast Asians with IF. But I do see the changes in the imaging. The microsteatosis is improving. Just with the IF. What are your thoughts, or do you have any data on that specific population?
Yeah, I have relatively few patients of South Asian heritage, but I have no doubt that people who practice and I'm assuming you use the 16/8 version of intermittent fasting, which is the most popular version of it. There are other versions out there. For someone that's practicing it very well and being very mindful of that 8-hour eating window, I'm sure it's going to help. There's no question about it. You're an endocrinologist, you are decreasing your insulin drive. Your insulin will go down, and that helps the liver because the steatosis is really coming from hyperinsulinemia. And so I have no doubt that someone who practices it very well will do it. In my clinic, though, I'm seeing some individuals that have none of those benefits. And part of the reason is a very high caloric consumption in a very short amount of time, late in the day, usually after 6 o'clock, when there is that metabolic switch happening in the body from oxidative phosphorylation to glycolysis, as you know. So it's challenging. I have no doubt that someone is doing it with right labor benefit. So no, I'm not suggesting the technique is wrong. I just think that for some individuals, it may be a very challenging thing. Now, I have to say, final thought there is that in clinical trials, there's actually no difference between intermittent fasting and any other form of dieting, as long as you're mindful of your diet. I think that is the message. There's nothing magical about it.
One question.
Hi, Dr. Behari. Very nice talk. Thank you. I have a very simple question, but it is very confusing. You recommended decreasing the consumption of sugar, but with the surge of all these products on the market, with sucralose, stevia, monk fruit, erythritol, how do you compare those products, protein shakes, protein bars, all these things on market? How do you compare these ingredients compared to regular sugar, and what do you recommend out of those products?
Yeah, that's such a great question. I wish I'd included that in my talk. But so yeah, you're absolutely right. So the way I think about artificial sweeteners is like a nicotine patch. If you're smoking a cigarette and you want to go achieve a state of non-smoking, it's a great stepping stone towards it. And so if you're having a very high amount of sugar and you want to achieve a state of no sugar, I think it's a good stepping stone because you kind of improve some of the glycemic effects and hyperinsulinemia. The challenge, though, is that at least our current understanding of the pathophysiology of MASH is that the gut microbiome plays a very profound impact on the disease progression. So there is something about dysbiosis in individuals that have progressive liver disease. Perhaps there's other factors downstream, such as genetics in the liver, But gut dysbiosis is affected by consuming large amounts of aspartame, for example, in Diet Coke. And there's some studies suggesting that different artificial sweeteners have different impact. There just is not enough data about that. So that's one thing. So I think that, yes, it's probably a stepping stone, but I have yet to see someone that has only Diet Coke or large amounts of any sugar-sweetening substance that is completely healthy. I mean, it's just not my experience. The second important thing, though, is that there's some data emerging that individuals that have a large amount of artificial sweeteners subconsciously eat more calories because it dysregulates that very complex neurohormonal circuitry. So your brain is expecting the calories because it's tasting the sweet, but the calories are not appearing. And so you may subconsciously consume more calories if you're having a diet drink with a regular meal. So I think much more research needs to be done. I am unconvinced that they are completely benign substances. And so perhaps the best thing would be tea, coffee, and water, which are traditional drinks, certainly for some Asians. I think it's the best strategy, at least as an aspirational goal. I'm not suggesting it's easy to get there.
Okay. One last question.
Hi. How young does the MASH start? And when it comes to dietary modifications, how young should we start? Teens or even younger?
So a very common refrain from parents and grandparents is, well, we have cookies in the house, or we have, a soda in the house because we have grandchildren. I would flip that and say, because you have young kids, you have to adopt a healthy lifestyle. And the reason is that I worry sometimes because the average age of advanced MASH is decreasing in my clinic over the years. I suspect that by the time children are 5, 6, 7 years of age, they are so addicted to sugar. Every reward in their life is linked to a sugary substance. So if you play a soccer game and win the game, well, guess what? The prize is Coke and pizza. If you do well at school, well, guess what? We're baking a cake at home. So we are so programmed to keep sugar as a reward system in our lives that children, by the time they're in their teens, etc., are very difficult. So I would suggest that perhaps minimizing it, consider sugar to be like a potentially highly addictive substance for some people at least. It's better never to expose them or as little as possible. And the longer you wait, the less likely they are to develop that dependence.
Thank you. Thank you, Dr. Behari, for an excellent talk. And